Eunice, Victor, welcome back.
Bashir, Ali. Karibu sana. Oh, nice. Bekaria, karibu. Welcome, guys. Welcome. You know, we're doing this vascular anatomy with Dr. Newsome, Dr. Gichoya. So we have the experts in the house, and we're gonna be starting in the next 2-3 minutes. As is it Dr. Newsome is starting today?
Yeah, she is. I'm just going to piggyback, and you can do the same, Walter, for high yield facts. Okay, when you hear something.
For sure.
Okay?
For sure. Yeah.
Yeah. Otherwise, I'll end with a summary, but it should be good. I think it's a good lecture.
Sure.
And guys, we're gonna get better at doing this and give more,
Yeah.
all of us, because you're gonna provide feedback and we'll incorporate it. So we're gonna get better at this.
Sounds like we have more than 17 people here.
Yeah.
And this is a good sign. Mm-hmm. So guys, we're gonna start in the next 1 minute. Welcome for those who are joining us right now. Dr. Judy, Dr. Newsome, they are in Georgia. I'm in Iowa myself. So, and most of you might be in Kenya. So we're bringing the world together to learn. And I'm super, super excited about that.
Where's everyone joining from? Maybe we can put on chat. I know we always ask this question every time.
Yeah, it's a way of connecting, I guess. Where are you guys from? Are you from Nairobi, Mombasa, Kenya, Rwanda? I think the Rwanda students were to join us, right?
Yeah, some
I'm
have
not sure.
joining us, yeah.
I'm not sure if they are here.
Dr. Gichoya and Walter, in the short space of time, I have spilled coffee on my jacket.
I see.
Sorry for that.
That's okay. So now I have to wear my coat, my lab coat. All right, let's see. Too much light here. Let's see if that changes anything.
Okay.
Is that better?
Yep, yeah. It's good. I think we can start. We are 3 minutes in, so anytime from now, guys, we're gonna start. So be ready for questions, answers, for brainstorming and all that.
I'm ready.
Mm-hmm. Okay, do you wanna share your screen?
Me, Gichoya?
Yes.
No, I think it has to come from you. I didn't.
Go to box.
You so.
Oh, God.
All right, so I have it then.
Mm-hmm.
Okay, not quite, because I have to share my screen first. So everyone will see all the messages.
Dr. Newsome, what are we gonna teach, Dr. Newsome? Say karibu.
Yep.
Is that what we're going to teach me today?
Yeah.
That's how you welcome
people.
Yep.
You wanna try?
Yeah, I'm trying it now. So am I usually sharing desktop?
So you open the slide, then
no.
Oh yeah, you got it.
She has taught me this 1,000 times, and she's going to be like really mad if now you're teaching me this again. She's going to be like, this is what's happening. Judy, what screen are you seeing?
So I'm seeing the screen with mountains.
That's not good. So now
that's okay. Just drag the PowerPoint to that side and.
How about now?
I see Emory University School of Medicine as the first slide.
Okay, is that okay?
No, swap displays.
Okay, hold on.
Swap displays at the top there.
Hold on. Because that is not, oh, so I see what's going on. It's I'm using like 3 screens.
Yeah, that's okay. Just click on Zoom and swap displays.
Hold on, my friend, my sister, my brother. Click on Zoom and swap displays. I could tell you that I don't even see the thing for the Zoom, so just give me a minute. Oh, 1 minute, Judy. I'm not as illiterate as it seems. Click on Zoom.
Why don't I take control of your...
Hold on.
Give me permission to... Okay. Okay.
Yeah, we got them. Awesome.
I'm just going to give you back control. Do you want to go back to the first slide? And can you see your slides? Okay. I can also share the slides too.
Hold on. Is that, I just did that. Can you see that slide?
Yeah.
The second slide and the third slide, right? So you're able to.
Yes.
Yes.
Can you see?
Yeah.
Yes, we can see.
Okay, because I have my camera in some weird angle. All right, but that's good.
Okay.
I'm ready.
Okay. Thank you, everyone. Welcome to this neuroanatomy revision.
Not neuroanatomy.
Vascular anatomy revision, sorry. And we have Dr. Newsome, interventional radiologist from Emory University. We have Dr. Gichoya here today, also joining us from Emory University. They work together in the same department. They look like the duo who really work very well together. And today they are joining us, guys, to just help us learn all this in preparation for exams, in preparation to take care for our patients. So I want to take it away, Dr. Newsome, Dr. Gichoya, and I will put my video off. Welcome, everyone.
Good morning, everyone. Thanks for joining. I think we have like quite a few material that we want to try to cover over these last hour or so. Parts of this is going to be very interactive. I want to say it is my pleasure to be doing this, and I want to thank Dr. Gichoya and Walter for even asking me to be involved in this project. But here we go. Like they said, I'm from Emory, and I am pleased to be here. Now let's see if I can get this to go. All right, just if you can.
It's going.
Okay, fantastic. So we're going to talk a little bit about what I consider the basics, the nuts and bolts of how we take care of people. And yes, I'm talking about the blood vessels. So we know that healing begins with knowledge. So let the knowledge begin. I'm an interventional radiologist, as Walter said. I work with Dr. Gichoya, and one of our things that we say is that interventional radiology is like surgery. It's only magic. I'm from Jamaica, so we always would say as well, like being a good interventional radiologist is being like a good thief. Like you sneak in and you sneak out, and what is left behind is just a blanket, is just a Band-Aid. So it is, it would take another lecture for me to explain the significance of a giraffe versus a turtle. But if you've ever heard me talk about anything before, I won't just go into the medical side of it, because I believe that in order to be successful, that you absolutely need the medical side, but you need inspiration and you need instinct. And my inspiration for you today is the image on the right, is the giraffe versus the turtle. And that both animals have a long neck, but one animal is being held back by a hard shell. And the key points of this here is knowing which one of these you are. And I would say that if you're hearing my voice, I know that you are the giraffe type. So please, please, please do not take advice from a turtle, another long neck animal, but definitely held behind by a hard shell, because what a turtle can see is only as high as a shrub, but what a giraffe could see is as tall as the trees. So please stretch your neck today, be a giraffe, and know that you should not listen to the advice of turtles. Okay, now,
I apologize for Dr. Newsome's safari analogies, because clearly they usually don't make sense to me after working with her for quite a while. So apologies in advance.
Okay, so no more safari analogies, I hope. But maybe we can let the games begin. So we're talking about vascular anatomy, and we're going to do it from the head to the toe. We hope wherever we stop, we'll just stop and respect the time. But we will begin again wherever we end. Today, we will not be covering the venous anatomy. That will also be for a whole nother lecture. And I will also be excluding the anatomy of the heart. But hopefully, we'll start from everywhere else. So this will be a little bit of a test. So let's begin. If you can put in the chat, can you name these branches from 1 through 7? What is branch 1? What is number 2? Number 3, and since we need some answers that are better, that are best, I'm going to ask Walter to also participate. Please name the branches 1, 2, 3, 4, 5, 6, and 7. And for extra bonus points, you can actually, let's see, bonus point would be, I'm going to see if I can put my arrow here. What is this branch called? Dr. Gichoya, I cannot see the chat, so I would expect you to chime in and let me know if people are able to respond. What is 1? And we will give another 30 seconds. I definitely want some participation. What is branch 1 called?
So branch 1, Victor, Brian, Pauline, Akshay. Note that this is the brachiocephalic.
Okay. And we know that this is an artery, correct? Brachiocephalic artery. What is branch 2 called?
So branch 2, Brian, Victor are saying this is the right subclavian.
It is the right subclavian indeed. That is fantastic. Awesome, awesome, awesome. Okay, can't trick you guys. What is number 3 called?
Still waiting on some answers from number 3.
Okay, number 3, we're waiting for some answers. Going once, going twice. Anybody?
That's a common carotid from many people. Walter, Victor.
Okay, that's right. It is indeed the right common carotid. The right common carotid. I know that Dr. Gichoya spoke last week and Walter about this, handedness and how images appear to be flipped on a radiograph. So this is the right common carotid. How about number 4?
There's an early mover, Brian Sifuma, who said number 4 is the vertebral artery.
It's the right vertebral artery.
There's also that number 4 is left common carotid.
Okay, okay, number 4 is the left vertebral artery. Number 5 is the right vertebral artery.
No, flipped, right? 4 is right vertebral artery.
I'm sorry, yes, and the left vertebral artery, I'm sorry. And number 6 is the
Common.
Left common carotid artery, fantastic. And number 7 is the left subclavian artery. You guys are amazing, doing great. And for bonus points, where is this arrow pointing? Does anybody know?
Give 30 seconds.
30 seconds, if you can see the screen. I'll act like I'm in church. 10 seconds left.
Costocervical, internal mammary.
The internal mammary. Okay, so I think that the better answer here would be that this is the right internal mammary artery, and that is awesome. You guys are doing amazing. So the arch anatomy, I think we can go through exactly what it says now, and I don't even have to do this anymore. You guys already got it, right? You have the right brachiocephalic, the right subclavian, the right common carotid artery, left common carotid artery, left subclavian artery. We're not going to talk about the coronaries today. And on angiography, when we do these images, right, which is where I started from, where I could have shown you these stick figures, you can see clear as day the right brachiocephalic trunk, again, right common carotid artery, left, right vertebral artery, left common carotid artery, left subclavian artery out here, left vertebral artery. And again, the bonus point was the internal mammary arteries. So knowing
that would be the right internal mammary artery.
That would be the right internal mammary artery. Where people are mostly looking for the internal mammary artery, we have a image of that in a case coming up. So knowledge of the normal arch anatomy is important so that you can identify what are the variants in anatomy. So the usual pattern, you would think that we will see very often, but that is only seen around 65% of the time. So if you think about that, that there's going to be another, fairly substantial percentage of the time where it is not going to look just like that. And the next most common variant is where the left common carotid artery arises from the innominate artery or the brachiocephalic artery and doesn't come off the arch directly. Or where there's a separate origin of the left vertebral artery. Instead of that arising from the subclavian artery, here the left vertebral artery will arise directly from the aortic arch.
So guys, I just want to say that, and we'll tag team this, all the three of us, is that this, the innominate artery is another name for the brachiocephalic trunk, right? And the right side, remember, this is how we did it last time. So sorry if it's too simple, it's just about repetition. So the right side is mainly coming from the brachiocephalic trunk, and then the left side arises straight from the aorta. And then if you look at this, so the three vessel arch is the normal one, right? The figure A. If you look at B, and we'll talk a little more about this, what I want to emphasize is, if you remember, and just trying some things together from the last lecture, is that if you remember where we said the circle of Willis. Now, if you had type B and your right carotid artery came from, and there was a common origin of the brachiocephalic trunk and the left common carotid artery. So if you have something that's going to affect that, it's going to take away all your anterior circulation of the circle of Willis. So I just want you to think now, and we'll come back to this in a future lecture when we look at neuroanatomy pathology, then what sort of symptoms will you get in this case, So if you think also in terms of like C, and I would hope that I don't have the type D type, because if you take away everything from that one single trunk, then you would have no circulation to the brain.
Thanks for mentioning that, because it isn't just for knowing's sake, right? It is knowing because these have implications clinically. So yes, there are some test questions that are just asking you for memorization's sake, but you really need, the memorization part is hardly the issue as it relates to being a good doctor. So people are used to this phrase, a bovine arch, like someone that has a bovine arch. But let's really look at what this cattle arch is like. It is that what Dr. Gichoya was talking about, having like a single trunk. And that is actually rare. We don't necessarily see this bovine arch with this bicarotid trunk as often. This is what that looks like in what we call a bovine arch anatomically in human beings, but what a cattle really looks like is not exactly the same as this bovine arch. Does everyone understand what I'm saying?
Yeah.
Yes, just a misnomer. Something else about the aortic arch, and we're only in the neck and we're moving to the toes, right? So I don't want to spend a lot of time on this because you guys have got this, the name, the branch is just fine. But remember, as folks get a little bit older, right, the arch becomes a little bit more ectatic, and the origin of the vessels in relationship to the, where it comes off on a horizontal plane would be a little bit different. So let's look at that. as someone becomes, and again, I won't spend that much time on it here, but just know that a type 1 arch, it is still the same arterial anatomy, 3-vessel arch, but it's just, if you draw a line across the origin and the top of the aorta, you'll see that the origin of the common carotid and the right subclavian would be a little bit lower and gets even lower as the arch becomes more ectatic. And this is a very common thing in the aging arch or folks with hypertension. This is an advanced question for our fellows in terms of dealing with type 1 arch, type 2 arch, or type 3 arch. Just to let you know that you'll see those numbers that are not related to the arterial vascular variations. This is simply relating to the ectasia of the aging arch and have nothing to do with where the origins come off. Okay, I think we've beaten that into it. So let's talk about some of the diseases that affect the arch. Can anybody tell what this, what the abnormality is here? Just type that in the chat. I know that there's an arrow sign that may be helpful. Dr. Gichoya, Walter, could someone help me with the chat, or I'll have to figure out how to do the chat here? Or, okay, I think we got it. There's some excellent answers. The arrow is pointing to what looks like an occlusion or something of the left subclavian, correct?
Yeah,
correct.
So there's something called an answer said obstruction. Yeah, obstruction or occlusion of the left subclavian, right? I'm going to show you another image, right? So these are companion images, right? So when an angiogram was done, here where we have a catheter coming from the groin, with the black being the X-ray dye, injection in the ascending aorta, you can see the normal, innominate or brachiocephalic artery here on the right, the left subclavian, common carotid artery, and then here at the left subclavian, there's a nub, right? So one way to prove what this exactly is that another catheter was born from the groin and the right vertebral artery was catheterized. And injection of that vertebral artery was done, and you can see the entire vertebrobasilar system into the brain and down into the opposite left vertebral artery that then backflow, filling the rest of the left subclavian artery and down the left arm. Does anybody know what this phenomena is called? And bonus points for if you know how the patient will present. This is
Let's send to Gichoya.
Yeah, Doreen says this is subclavian still.
Oh, look at that. That is a
Triple S.
Triple S, subclavian steal syndrome. I love it. I love it. Okay, you know what? I can let you guys share my slides and then you can give me this lecture, right? So, that is awesome. So again, subclavian artery stenosis that will lead to subclavian steal syndrome is, left is more common than the right. Most of the times patients are just asymptomatic, and they're found where, you have this blood pressure differences of greater than 20 millimeters of mercury from the left arm to the right arm. But what patients will have is they will have syncope or dizziness when they're using the left arm. Okay, so someone doesn't come in and say, oh, doctor, I'm using my left arm. And there's like, every time I go up to get the jar from the top of the shelf, then I feel like I'm going to pass out. Right? They give you a story such as that. Or I have this like intermittent, type dizziness. I have, lack of rhythm when I'm doing my aerobics. Well, that's not just because you're a Dr. Newsome, who has lack of rhythm all the time, just cannot dance. But it could be, I have poor hand-eye coordination. I have poor posture and fatigue. I just can't get it together. I have clumsy gait and movement, or I have exaggerated movements when I'm trying to get things. These are all a tendency to run, and whenever I'm running, I fall, I trip, I bump into people and things. They're very, very common type things, and you need to be thinking in the back of your mind, could that be it? Maybe I should take the blood pressure from one side or the other, right? So
I just want to go back to that slide. This is like super, super, super high yield, right? What Dr. Newsome described was, you know, thinking from Walter, right? Cerebellar dysfunction, right? And you have to remember, where does the, you know, vertebral artery, you know, go and supply. So we went through this last time, but this is that sort of tying clinical sense to make sense of what you're looking at, right? So this question can be simply, what's the diagnosis, right? It could be, what's the symptoms, right? It could be that the stem is saying, I measured blood pressure on my right side and on my left hand, and there was a difference, right? So you have to be on top of your game trying to figure out some of those questions.
okay, thanks, Dr. Gichoya. All right, let's look at it. Let's look at a case that is really going to tie this whole thing together. So this is a 67-year-old who has 2 prior carotid artery bypass, and you know, they've been having everyday chest pain, angina. Every time they try to do something, they have chest pain. They had prior angiograms that just show that their bypass looks open and they have normal left ventricular function. This patient has atherosclerotic disease and incidentally has bilateral lower extremity claudication. That is where whenever they walk, they have pain in the legs and calf, and they have a baseline serum creatinine of 2.2. So this is someone that has, you know, systemic disease. But we're really talking about just what's going on in the in the chest. So we know that this patient has a conduit. Their only remaining blood flow to the myocardium is a left internal mammary artery to the LAD. And every time they take a picture of this, it looks like this conduit is wide open. But in the office, there was this blood pressure discrepancy from the left arm to the right arm of 60 millimeters of mercury. So based on this clinical history, every single person that is in this chat should be typing SSS, right? They think that this is, but this person isn't passing out. They're not clumsy. They're not, but if you think about what I've said here, that the lima, the left internal mammary artery, is going to the LAD, then it makes perfectly good sense. Oh, this image is not going to play, but let's see if we can show another still image where, you know, if you look here, this is a catheter that is into the left subclavian artery. And if you take a picture of this, you'd be like, this is the left vertebral artery. This is the left internal mammary artery. It looks huge. The rest is the left subclavian artery. And you don't see anything here. But in radiology, one view is no view whatsoever, Dr. Gichoya and my animations. Right? But here you can see that if you just get another view, right? Just an LAO, it shows clear as day that there is a tight stenosis right here. So it could absolutely be that this stenosis is affecting the blood flow through the left internal mammary artery to the patient's LAD and is the culprit for the chest pain. Can we do something about this? Of course. We're the Bob the Builder. Can you fix it? Of course we can. And this is where, oh, that is I should not have used that analogy. Bob the Builder is a cartoon in the US, and they have a little slogan that says, you know, I'm Bob the Builder. And it's like, can they fix it? Yes, they can.
Dr. Newsome, MT is asking, what is LAO?
Oh, LAO. Let's go back to that. Dr. Gichoya, what is LAO? So LAO is a projection for left anterior oblique. So AP is like a frontal view of the chest. And in the left anterior oblique or right anterior oblique, these are projections in radiology that, that allows you to turn the patient or to turn your image intensifier or flat plate detector, whatever it is, to get a different view so that you can you know, see things much better. I think Dr. Gichoya may have touched on that, last week when she showed that, one view doesn't really show you anything. And I'll continue to harp on that as we continue our lecture series. Does that answer the question? I hope so.
Yes.
Okay. So to fix this, this patient could go back and try to have surgery that would include a thoracotomy. This is a shameless plug, but nonetheless, that here you can see this is an image where there's a catheter coming from the groin, from the left or right common femoral artery up the aorta. These two dot markers that you see here are balloons where there's a stent that is going to go up. And so when we inflate the balloon, then it will deploy this balloon expandable stent across the stenosis. All right, that's not what we're here for. So we're not really talking about it, but I'm going to show you an image much later on. So the indication for fixing this, as I told you, that a lot of people will have subclavian stenosis that are asymptomatic, right? The indication for fixing it would be what we talked about, subclavian steal syndrome. The syndrome refers to then the clinical features and not just the findings radiographically. Arm claudication, angina in patients that have had a left internal mammary artery. Occasionally you can have these areas that where it's occluded, it forms plaque and then thrombus there, and then it embolizes down the arm and causes ischemia of the fingers. Vertebrobasilar insufficiency, what Dr. Gichoya was referring to, that you remember that this is all a part of that posterior circulation, and if people are falling out and getting dizzy and unable to have their regular life, then that would be an indication for fixing it. And every now and then we're asked to do a procedure where we're fixing this in preparation for using the Lima or a subclavian bypass to something else, that they will ask us to fix this preoperatively. So these are some details of how the procedure is done. I think that it may be a little bit too much, but wanted to emphasize that after these procedures are done, stents are placed, that it is important that patients are maintained on anticoagulants or antiplatelet medication during the procedure. We keep the blood nice and thin so that you don't have blood clots during this, and that we keep them on dual antiplatelet for at least 3 days. And now I know that there are studies that are indicating 3 to 6 months. So here is again that same patient in still imaging, right, where there was that subclavian artery occlusion or stenosis. This was an occlusion that was eventually passed. Again, remember we talked about the internal mammary artery graft, right? And then after that, balloon expandable stent was placed, and placement of the stent is crucial because you still need to maintain flow in the vertebral artery, where you will now be able to have antegrade flow, right? Whenever the heart beats, now you'll have flow from the arch through the subclavian stent, antegrade into the left vertebral artery, into the brain, when previously this person was having retrograde flow from the brain down the vertebral artery and down the arm. Now you can also have antegrade flow into the internal mammary artery and into the LAD. Okay, so I think any questions about the arch anatomy, some of the clinical significance of the arch arterial anatomy, and how it is fixed or managed?
There's an anonymous attendee. Where is the arrow pointing? I'm not too sure that we'll figure out. I didn't see that.
I think, I'm not sure maybe what arrow it is. I'll try to be careful about where my arrows are pointing.
Yeah, sorry.
Oh, if it's this arrow, it was just to show that, this is a poor arrow.
Something absent there.
Yeah, it was showing that there is no flow here. You don't see the arch at all, that the subclavian artery is occluded. All right, so we're done out. I'm not going to talk about the thoracic aorta during this session. We will talk about that when we deal with, let's say, hemoptysis and treatment of hemoptysis. So onward to the abdominal aorta. So the abdominal aorta is, we consider that from T12 to L4. And let's make sure that I have the right, Dr. Gichoya. I think I may not have the, maybe I do. Okay, let's just go for backwards. The T12 to L4. And if you look at what are the branches from the abdominal aorta, you can think about where do we have single branches, where they're not paired branches. It's the celiac artery, the superior mesenteric artery, the inferior mesenteric artery, and I threw in here the median sacral artery, and we'll point those out and talk about it. So the celiac artery rises around T12, the SMA around L1, and the IMA around L3. And then you have paired branches where there's one on either side, where like the renal arteries or the gonadal arteries, whether it would be testicular or ovarian artery, depending on sex. So this is what the abdominal aorta would look like angiographically in the frontal projection, AP projection. We see the paired arteries much better in the frontal projections. Sometimes the lateral projection is needed for seeing the origin of the visceral arteries, the celiac, the SMA, or the IMA. You do not have to pay attention to this contrast injection or whether or not this is on digital subtraction angiography. And this digital subtraction is just referring to the fact that we are seeing more of the blood vessels, but you don't see the intestines. I'm not showing you the bones. I'm not showing you any other things. So those are subtracted out so that you can see mostly the vessels. I'm trying to get a sense as to how much in depth I need to go. So if you could please humor me and put in the chat, see if you could identify these vessels. 1, 2, and I'll try to point that out in case you can't see it very well. This is number 1. This is number 2. Number 3. What are these vessels number 4, right? It's hard to see exactly number 5. And so I'm just drawing out where number 5 is. And I'm gonna wait.
Can we start with number 1?
We can start with number 1. We can do number 1 and 2 together.
Okay, sounds good.
Walter, am I stressing you out here?
No. No.
Like, okay, slow down there, Newsome, slow down.
And there's a question as we label this. Please point out where we should see the marginal artery from AV. Just put it in the back of your mind, maybe as we move ahead. So number 1, there are several answers. Right renal. Number 1, 2, celiac splenic.
Right.
Number 1, renal artery.
So that is so unfair, right? Because I didn't give you any bones. I didn't give you anything, just this image, right? So you can't see what it is supplying, but you're right that very further up, you should be able to see like the celiac and the SMA, which I didn't really point to just yet. We're going to get to that. But number 1 is the right renal artery, and immediately across from it is the left renal artery. So kind of a trick question, and somebody fell for that, but the better answer here would be to say that number 2 is the left renal artery is immediately across. You, if you were my fellow, I would say you should be expecting to see a little bit more blush, but this is the left and right renal artery, main renal arteries. Number 3.
And maybe another thing around there, if you cannot, I mean, they won't try to trick you for this, honestly, for some of the stuff, but remember, these are paired arteries, right? That's, although answering celiac, splenic, I think is okay, but maybe just also look at below it. We don't see any other many visceral branches that would tell you that, you know, you're high up in the aorta. Okay, number 3, there's abdominal aorta.
Fantastic. Number 3 is the abdominal aorta. Number 4.
Lumbar arteries and the left ovarian testicular artery.
Okay. I actually haven't pointed out the left ovarian or testicular artery, but I'm glad that someone pointed out that those would be traveling in the lateral margins of of the aorta. So you would see the aorta in the middle, and you'd be seeing the ovarians, testicular or ovarians on the side. These are actually just lumbar arteries, one higher than the other. Am I correct, Dr. Gichoya?
Yeah.
So these are just lumbar arteries.
Okay, 6, 7, right? Common.
Hey, number five.
Sorry.
Is
I'm taking a challenge on number 5.
number 5, and I wouldn't either. I believe you. That is like, wow, what kind of trick artery?
Gonado. Number 5, gonado. So
Yeah.
remember gonado.
Go ahead, Dr.
Gonado.
Yeah, this is the phone a friend. You can, Dr. Gichoya is the friend.
Oh, IMA from MT.
It is the IMA. It is indeed the IMA. It is indeed the inferior mesenteric artery. And on the frontal projection, this is what it looks like, right? Like I said, in order to see the origin of the celiac, the IMA, and the SMA, you really need an oblique or lateral projection. But on the frontal projection, this is exactly what it would look like. Totally unfair.
So just remember the people who answered gonado, one of the earlier slides Dr. Newsome showed, they were paired arteries, right? Renal are paired, gonado are paired. That's also, I mean, sometimes you cannot say it, but if someone wants to try and trick you, the thing is not to be a radiologist, so it should be a little like more classic imaging. Number 6 and 7. Sorry, what?
Number 6 and 7.
Yeah, so many people have answered that. Right common iliac, left common iliac.
Fantastic. How about 8?
External iliac.
External iliac artery. And number 9, internal iliac artery. This is also referred to as the hypogastric artery, right? But the better nomenclature should be external iliac artery and internal iliac artery, as is number 10. So 8 is to 11, right? Both are the external iliac arteries, and 9 and 10 are the internal iliac arteries. Okay, let's see who gets number 12.
Sacral artery.
Okay, fantastic. Okay,
everyone knows this. There are like many median sacral arteries.
Oh, so you're like, everyone knows this Newsome. Let's move on. Okay, let's look at something that maybe no one knows. I need to earn my pay here today. So let's talk about the AAA. You guys raised it up a notch and gave me the triple S in the chest. And now we're going to talk about the AAA in the belly. So AAA refers to the abdominal aortic aneurysm. This is something that is like very, very common. Lots and lots of people are diagnosed with it. We know that it is most common in people that are above age 65. Up to 6% of them would have an abdominal aortic aneurysm. And guess what? Today, I'm a little bit older than I was yesterday. And as the population keeps aging, so is the incidence, the number of abdominal aortic aneurysm is really increasing. We believed that this was more common in males, but I think that those numbers are actually changing. This slide is dated. So the diagnosis of when do you call the abdominal aorta aneurysmal is where there's a dilation in the size of the aorta that is 1.5 times normal. Dr. Gichoya, maybe you can show, because I've not seen this very well. Measuring the aorta is, and this is really more from a radiology standpoint, and I don't want to go ahead and make you into radiologist, but I want to point out that, how people measure the aorta and when they say that something is aneurysmal can be very varied, but we really need to be thinking about this from the outer wall to the outer wall. Because let's say if we show a picture like this, right? And you measure just the luminal diameter, the part that is white, that is actually not the size of the aorta. That is just the part that continues to have patency of the lumen, but there's actually also the thrombus that is also within the aortic wall, and this is what I would call an impending rupture. Someone that is actually had an aorta that is leaking, and then there is definitely a inflammatory tissue that is around it. Dr. Gichoya, can you bring more light to what I'm trying to say?
So, I mean, this is just an image that even if you cannot tell what's going on, what you should be able to do is tell the from the history, right? It's a big aorta, the walls are getting sick, and the reason why we treat abdominal aneurysms is because we want to prevent rupture, right? Because we know that once there's
No, you can go on from it. It is not just to say, hey, I can measure, I know how to measure outer wall to outer wall, but we know that the reason that we need to pay attention to the abdominal aorta, right, is that we know that as you get older that it can become aneurysmal, and that the point of this measuring profusely, as sometimes the size, is to help to introduce treatment to prevent rupture. So small aneurysms tend to be, it's still aneurysmal because it's 1.5 times the size of the normal abdominal aorta. 15 to 20% of them just never expand, right? 80% will continue to increase in size. This is what we know about the natural history of abdominal aortic aneurysms. We know that AAAs, 25 to 41% of them that are greater than 5 centimeters will rupture in 5 years. And so when I see patients and I'm talking to them as we're watching their aneurysms and they get to be around that size, we start telling them that, we know that there's an increased risk of rupture at this size. When aneurysms reach around 7 centimeters, then the risk for rupture becomes even greater, not measured in 5 years, but measured in percent risk rupture per year. This is way too much. I think I'm just making you guys into interventional radiologists already. So that's too much to know. Just know that we can treat it, and that the treatment is aimed at prevention of rupture. Surveillance is important, and surveillance can be done with CT and ultrasound, and now where CTA and MRA is done as surveillance after endovascular treatment. So aneurysms are also described a little bit differently, whether it's diffuse, whether it is focal. We describe abdominal aortic aneurysms in terms of how is it in relation to the renal artery. Is this a juxtarenal aneurysm? Is it a suprarenal aortic aneurysm? Or is it an infrarenal, purely infrarenal aneurysm? Is it a focal aneurysm, or is it diffuse? How the aneurysm is shaped is also used for its description. Is it a fusiform aneurysm, one that is generally growing, gradually, or is it a saccular aneurysm where it just has this outpouching? Our aneurysms extend into the iliac arteries, all the way into the iliac arteries. And then just know that if you have an abdominal aortic aneurysm, 10 to 20% of those patients will also have a popliteal aneurysm, right? So it is not important, it's not just to describe that you have this abdominal aortic aneurysm, but also to remember that, hey, maybe my patient will need to be screened for a popliteal aneurysm. Let's look at this image. These are CT images that show a saccular infrarenal aortic aneurysm, nice and juicy saccular aneurysm that says, please fix me with a stent graft. Like there's absolutely a way that we should be able to go in and realign that aorta from inside out, right? Saccular, infrarenal, abdominal aortic aneurysm, as opposed to this particular aneurysm, which is not saccular at all. It is more a fusiform aortic aneurysm, and the image in here that the open operative image that definitely shows that. Again, talking about how we describe aneurysms, that we would also be saying, does this aneurysm extend into the iliac artery? And this CT image here shows that the aneurysm extends into the celiac artery. I want to go back to this other thing that we were talking about earlier, how you see the contrast that is highlighting the lumen only, but that this has a fair amount of thrombus, and that the wall of the aneurysm, if you were going to measure it, isn't just these inside parts where where it's white, but that the whole aneurysm extends from the outer wall to the outer wall. This is a bonus point here. I know that this is not fair. It is hard out here and it's not fair. That this arrowhead points to what? Not just an aneurysm, but I'm hoping that someone will be able to see that there is a, oh, I know you're typing it already, a dissection, that there is a dissection also of this iliac artery, and I have a few slides that will cover this. I just didn't want to lose the opportunity of pointing out that not only is this iliac artery a little bit bigger, but there is a dissection here. Dr. Gichoya, please keep me on target. I know I can talk and I talk too much. It's 10:51 and I'm going to shut up pretty soon. After aneurysm, we're going to go on to your slides, maybe.
Dissection is so high yield, so everybody should be able to identify that for the USMLE exams. So.
All right, so let's not talk about operative repair at all, but what you should be able to know is that in case it's you or your family or loved ones, you should say, oh yeah, we know that it used to be that you have to cut someone open and then you take out the thrombus and then we would actually put in a graft, sew those things together. But nowadays, you know, this is the operative repair the way that it used to be, but now we do this all from inside. Endovascular aortic aneurysm repair. I've always said that I'm a glorified plumber. Wherever things are small, I make it big. Wherever things are leaking, I stop it, except I don't get paid as much as a plumber. Here are some of the tools of the trick. Some of our grafts are supported on the inside where the metal struts that help to keep this graft open is on the inside, and some of them are on the outside. Just, you don't have to remember any of that. Just know that it is possible. What you're seeing now belongs in the museum. This is one of the first aortic aneurysm graft that was made, where we actually just put struts on an unsupported pants. We had to, I mean, Dr. Gichoya is going to talk about how old I am just from the fact that I have this unsupported anterior graft on the slide. But regardless, this, you know, if you understand the anatomy, if you understand the disease process, if you are able to figure out how to realign the blood vessels, whether it's from an outpouching or if it's from a stenosis, then you can actually fix this. So knowledge of the anatomy is important. It's not just the technical abilities or what the technology is knowing where to put the graft so that you are able to keep this patient alive. I'm not going to belabor the point, but that these have issues that are related to endograft leaking. And so there are other procedures that have to be done to make sure that the procedure itself is successful. So if you just look with me to this image all the way here, you'd be like, oh, Dr. Newsome, this is a fusiform infrarenal abdominal aortic aneurysm. I could see the right renal artery here. I could see the left renal artery here. And oh, incidentally, this patient happens to have multiple renal arteries, right? Not just a right and left. The patient has duplicated renal arteries. You just have to take it from me that this is also going to a kidney. You can identify the lumbar arteries here. And then this aneurysm extends into the left common iliac artery. This is the external iliac artery, as we talked about. This is the internal iliac artery. In this oblique, you can see the contralateral right internal iliac artery. and the left and the right common iliac artery. Now, in deciding how we're going to fix this and where we need to land a graft, we know that this common iliac artery is also aneurysmal. So it is likely that we will need to extend a endograft into the external iliac artery. If that's the case, we're going to be covering up the origin or the branches of the internal iliac artery, but it is still open. And so retrograde flow from the pelvis into the other side could come back and keep this aneurysm filling this the sac. And so in preparation for that, we went ahead and put these coils into the internal iliac artery on the left side so that we can block that off. And that allows, if you look all the way to the right, when the endograft is in, then you can see that the internal iliac artery is already occluded. We have a nice seal here, and so we should not be getting backflow from that internal iliac artery, creating what we call an endoleak, and where there's not good sealing of the graft material on this side. Too much material, join the fellowship. No, I'm just kidding. You don't have to become my fellow to do that.
I think there's something here we didn't talk about where you have bilateral occlusion of the iliac, internal iliac arteries. What symptoms do you get?
Okay, so type that in the chat. What symptoms would you expect to get if you have bilateral internal iliac artery occlusions?
Especially
I don't want to make it seem, say that again, Dr. Gichoya?
Especially in men.
Especially in men. I don't know why I'm repeating what she's saying when you can hear her. It's a common phenomenon.
Okay, there's impotence, bilateral claudication.
And the fact that Dr. Gichoya said, especially in men, I think she was phoning her friend away already.
Nairobi erectile dysfunction. Yeah, so that's like classic history, right? Buttock pain, erectile dysfunction. Then you should be thinking of internal iliac. We can go.
Okay, I'm going to run through this. I don't want anybody to think that any aneurysm can be fixed from an endograft approach. So there are limitations where there's extreme calcification or tortuosity. Look at this incredible angulated neck. It would be hard to figure out how to do this. This is an example, Walter, of an endoleak, right? Where you actually have the aneurysm that is being repaired already with an endograft. This is the native aneurysm wall with thrombus, and then this is someone that is having an endoleak. If you were my fellow, I would say, what kind of endoleak do you think this is? It shows us right here. This is where the IMA is coming back in and continuing to fill that aneurysm sac. All right, I'm done with aneurysms of the aorta. More than you'd want to know, that it is classified according to its relationship to the renal arteries, that it is classified as saccular or fusiform, and how it extends. Now let's talk a little bit about dissection, right? Another high yield question, something that Judy tells me that is something that I need to discuss.
Just before you talk about dissection, it's good to know that aortic aneurysm, we usually do preventive kind of surveillance, and mostly men who are smokers, and that's something that comes with the USMLE exams. And I think it's up to the age of 65. So you should know that for preventive medicine.
Fantastic. See, I'm glad I have all my friends here today. Should be called the J&J and Friends show. All right, so aortic dissection involves, again, it's a true and false lumen that is separated by a flap. When we do cross-sectional imaging, every now and then we can actually see this flap, but just know that this flap is not in a single plane, that this flap can be in and out of the plane of which you're doing this axial imaging, but it always involves a true lumen, a false lumen separated by a flap. That you must define, that it doesn't mean that always there has to be an aneurysm, that you can have a dissection in an aorta that is non-aneurysmal. And when you talk about dissection, you must define what the proximal extent is and what the distal extent is. Okay, so let's go to this. Dr. Gichoya, do you want to take this away so I can take a sip of my coffee?
Okay, so this is, you should know this, right? Because it's the classification of dissections. We have the DeBakey and the Stanford classification. And so what you have to know is where it starts from, right? So type A for ascending, aorta. And then remember the left subclavian artery is where the arch sort of ends. And so B will be beyond the left subclavian artery, as long as you can identify it, right? And so the treatment actually is super important here to know, because if you're in A, you remember we didn't talk about it, but Dr. Newsome had a slide where there was the coronary arteries, you know, the aortic valve, and then this big vessel supply to the brain. So that's what you want to preserve and save. So most of the time in a type A dissection, it's open surgery. And then type B, usually it's going to depend on whether you have symptoms, because let's say you've taken out your renal artery, or you're causing ischemia of the bowel or ischemia of the legs, like when you saw the common iliac dissection. And so those are the ones that are treated, and they can be treated by both surgery and interventional radiology, but interventional radiology is preferred. Like endovascular techniques are more commonly used. Remember, most of these things, if you have a flap, it's going to be propagated by hypertension. So hypertensive blood control is important. We're not going to spend time talking about urgency and emergency. You should review that. And but this is sort of the takeaway for the aortic dissections.
All right. So I again can talk a lot. I recognize that our timing is beside us. So I'm probably going to end at this dissection, and then Dr. Gichoya, if we can go to some of your slides that talk about, you know, summarizing like some of the principles that we've learned. But we still have much more to go, because we really have just we still have to talk about the visceral anatomy. We still have to talk about the lower extremity arterial anatomy. 1 hour is gone by just so fast. But let me just point this thing out here. When you look at an image like this and you're like, this is a coronal image of the chest and then the upper abdomen, clearly you can see that there's something that is like super abnormal. And your doctor, your examiners would be saying, could you tell us where the true lumen is or where the false lumen is? And you know, it really is sometimes quite tricky. We would sometimes think that the bigger lumen is the true lumen, but it is not so. It is usually the opposite, that the bigger lumen is the false lumen. And sometimes when you look at other techniques, like in the MR, where it is not where contrast is given, it is just sequences that allow liquid to be seen, it is hard to tell where the true lumen is or where the false lumen is. I would say you need to just scroll in and out, see where things are still being perfused. Very, very tricky to see at times, but take the time to try to see if there are ways that you could identify the true lumen versus the false lumen. When you look at this image here, I want to, if you can type in the chat, let's do this image. What type of dissection is this? Can you classify this dissection based on what you can see? Is this a type A, type B, if you're doing the Stanford classification, or the DeBakey classification 1, 2, and 3? Just let me know.
Today is B.
Right, so Stanford A and B, I've just put it back up again, the DeBakey 1, 2, and 3.
Quite a few people are saying Stanford B, Stanford B. People don't like the DeBakey.
They do not like the DeBakey. I don't even like Dr. DeBakey, so I'm just kidding. All right, Dr. Gichoya, maybe I should just run through your slides, or you want to just go all the way to the
finish the dissection up to the next theme.
All right, so I think that this is, you know, again, just looking at the imaging, that one of the things with the dissection, if I just showed you this image here, you actually could just see that, hey, here would be the aorta. I see what looks like, you know, there's contrast here and this side. But one of the complications of dissection is embolic disease. And clearly you can see in this image that this left kidney has some areas of hypodensity in a wedge shape. This is where one of the renal artery branches have been occluded, or where you have embolic disease. So there's differences in perfusion or flow to that kidney artery, and dissection should be thought of, even though you don't see it on this image. But clear, as you look up into the chest, you can see that here's a dissection flap of the thoracic aorta. True lumen, false lumen. And I don't have to ask anyone to put this in the chat. They're going to tell me, Dr. Newsome, B. This is a Stanford B, because they don't see any flap in the ascending aorta. This is indeed a Stanford B. All right, we're beating a dead horse, but there's no need to do that. I just want to do repetition that, again, make sure you identify the proximal extent as well as the distal extent of your dissection. That if I showed you just the image on the bottom, you would say this is a Stanford B, but you need to look a little bit more and you will see that this is a Stanford A. Actually, these are two different people. That this would be a dissection of the ascending aorta that is usually repaired surgically, although there are endovascular stents that are made now, and to even repair, I guess I would say a hybrid or a combination type procedure, where a graft is placed in the ascending aorta and then there is reimplantation of the great vessels, or even sometimes stenting through the graft into the great vessels. But you should say surgical repair of the Stanford A, blood pressure management or endovascular repair, including fenestration, which is a procedure where we poke holes between the true and false lumen so that we can get better flow to the areas that the false lumen alone is providing or blocking all flow to. All right, we do have a ton more to go through as in terms of the visceral arteries. So I'm going to stop at this moment. Dr. Gichoya could give us her parting slides, you know, her little nuggets, and then we will continue another day, another time.
As I share my screen, thank you so much, Dr. Newsome. Please say thank you to Dr. Newsome. And
thank you, Dr. Newsome. Thank you so much. That's amazing.
No, this is my pleasure.
Yeah, and then I'm just going to maybe just spend 5 more times and then give the floor to Walter here. So maybe Dr. Newsome will find finally her chat window so that she can see the many thank yous coming in.
I found my chat window. Thanks.
So I just wanted to put, so next week we'll finish this arterial, it's not gonna be me or both of us, arterial anatomy. There's just really quite some high stuff. We always underestimate how much we need to talk through. But again, as I go through the summary, please start providing feedback, you know, and just say what would like to be explained to better. And I just wanted to go back to the basics again here. We know that we have the 3 layers of the blood vessels, right? Intima, media, it's like the IMA, intima, media, and adventitia. And you have to understand sort of like the pathology and the pathogenesis that results in all these, you know, disease pathologies. So this is usually sort of like our gamesmanship type of presentation. So when you think of pathophysiology of vascular disease, you're either thinking of an abnormal response to the vessel repair when it's injured, an inflammatory infiltration, or an immune reaction, right? And so if you think about immune reactions, you'll have the vasculitides, right? Kawasaki's. if you think about inflammation and sort of what happens when the vessel is damaged, is what Dr. Newsome was saying, you know, that we have to give aspirin and Plavix when we put stents in these injured vessels to prevent the platelet growth. I mean, if you go back to review that part of the pathology, you'll see that, that's what happens. And then the location, you know, is important in terms of the pathogenesis. So like when the media is injured, then you start to get atherosclerotic disease, and the adventitia you get a fibromuscular dysplasia and SAM, at segmental arterial mediolysis. And so, but then we have quite some presentations on all these things in the remaining slides. But so if you have a thick wall, then you have a narrowing, right? And you have a weak wall, we've seen you have an aneurysm or a dissection. If you have a rupture, then I think you saw some cases that I showed last time of a pseudoaneurysm. You can have a fistula where you have the artery and the venous side communicating, and you can have just bleeding, and we have quite some cases of those coming up. And when you don't have any blood moving, then you have occlusion, and when you form clot, you can shower it to other areas. Very, very high yield in terms of like thinking of mesenteric ischemia. And so every time you think about this, we've been going through this, and we'll go through this again. You can either have a narrowed artery, a dilated artery, either dissection, a bleeding artery, a false lumen holding what would be something that's bleeding, a fistula, which is abnormal communication. Now you don't have to, you can remember the AV fistula by just remembering that when we need dialysis, we manually, intentionally create an AV fistula, and then in situ thrombosis and an embolus. And so in terms of sort of gamesmanship, when you think about characteristics of vascular disease, then you have to think about what are the findings, which I mentioned here, and then where, you know, the size of the involved vessel, and then what region, and what's the age of onset. Really, you have to remember these four things, because if you're thinking about size, then you have to think about large arteries, you're thinking of aorta, great vessels, which is where we've been doing the work right now. Medium sizes will be what Dr. Newsome will talk to next, which is the renal arteries, the carotid arteries, the superior mesenteric artery, and then the small vessels are more segmental branches, and then capillaries, we rarely see those. And so if you sort of think about size, then when you hear it's a large vessel, you can by now everyone knows, my mouse is kind of off right now, but you can see this arch. So you know that this is the aortic arch. We are looking at those great vessels that we went through. If you start to see abnormalities in those, then you know that's Takayasu. And this is giving up an answer that was coming up. This is the renal artery. We were able to identify it, but if you see this, you know, a beaded pattern, then you know it's from fibromuscular dysplasia. And if you see this sort of small microaneurysm pretty far in the small vessels, then you think polyarteritis nodosa. And so if you think also in terms of location, we have the, if you're thinking of renal arteries, it's FMD is most commonly there. If you're thinking of lower extremity and upper extremity vasculature, things like the Buerger's disease are things that you think about. And when you sort of think about age, you're thinking of childhood diseases, then you're thinking of Kawasaki's, early middle age, Buerger's and Leriche, and the late middle age, then atherosclerotic disease. So if you go back and sort of think and look around, this is in the US first aid book. Please go back to this page in sort of like cardiovascular anatomy, because you can start to figure out what are some of the big words that you can hear. And so for example, if you think about B, and if I say this is a young patient, right? And then, so you know that this usually will be Asian patients, less than 40 years old, and it's a pulseless disease. You know, you have weak upper extremity pulses. That's kind of intuitive now, because you know that you have the subclavian arteries. It's an inflammatory disease, so you'll have constitutional symptoms of fever, night sweats, and you may also have ocular disturbances and skin nodules. And this is Takayasu's, right? And if you sort of think of something like F, just following in the same thing, I showed an example of the polyarteritis nodosa. And then, so then you can go back and think about what, when you have these innumerable renal microaneurysms, and have a string of piles appearance, and the treatment is corticosteroids and cyclophosphamide when it's like an inflammatory type of disease. So please go back and review this, and at this point we can answer any questions. I see Siri is trying to listen to my conversation, but yeah, so the next one we'll have venous pathologies, PE, DVT, and Akima says, Dr. Newsome, I could listen to you all day. Pathology is always high. Plavix is clopidogrel, and many thank yous. I guess there are no questions, right?
Yes, so thank you, Dr. Gichoya. Thank you, Dr. Newsome. I think the presentation today was really a very awesome presentation. I think we will talk about the pathology.
We can't see your picture, Walter.
Oh yeah, I was moving from, my kid was making a lot of noise, so, okay. So,
they're future IR, so you should just bring them onto the lecture.
I think I should.
There's a question,
Okay.
Gichoya, in the Q&A section. They said there are questions in the Q&A section.
Oh, okay.
I answered them. So there's one question which was where the arrow was pointing and we couldn't really figure out because we weren't paying attention. And what artery was number 12, which was a median sacral artery. And then in transfemoral access for catheters, which side is preferred, right or left? We use both. Most of us are right-handed and we stand on the right side of the patient. So we'll always start with the right unless there's something wrong. Yep. And yes.
So
yes,
maybe
Walter.
Oh yeah, so I think the presentation was awesome. I learned a lot. I've forgotten some anatomy and all that, and thank you so much for reminding me. So the thing is, I think next week we have a slot. I'm thinking that it's good for us to continue and finish up what of the learning process, and especially the presentation like now you showed, Dr. Judy, like how to identify the clinical symptoms of polyarteritis nodosa, you know, Takayasu, just how you start before you look at the image, what you see, we can really learn those things. And I think next week we can, Dr. Newsome, if you have a chance next week, we can finish up what you started. And the week after, we're gonna do the ECGs and then move that way in cardiology. So unless you guys have any question or any other statement to say right now, what I want to say is thank you for joining us. And let's keep making medicine great again, I guess.
There's a question on the Q&A. Which dissection do you guys get, A or B? Just curious. So we see more of B though. We do get A, but you can imagine if you have a bad A, you die, right? So we don't get to image it, but I don't know, Newsome has been around for a while in this field.
That's her nice way of saying, let's ask the old people. So I would say, yes, so we tend to see a lot more B than A, but, and really, B is more prevalent than A, right? And it may be just, as Dr. Gichoya said, that someone that has a ascending aortic dissection that is acute, or even a type B that extends to a type A, or the other way around, we don't always get to image those.
Okay, Dr. Newsome, do you want to send us off with a final word? We'll give you offer.
Yeah, you know, and I think the final words are never, are always words of encouragement. And I would say to you today, just like I started at the beginning, just remember that that you are the giraffes, right? I'm drinking my coffee to, you know, as my reminders that, you know, look far ahead. Sometimes you feel that you're just answering these questions now, and you can't even think about, you know, how does this have anything to do with my dreams? You are looking at people that have gone through this process, that have been able to come through and now are living their dreams. And so I'm hoping that not listening to a lecture from Dr. DeBakey or people that you don't think that you can relate to, that you're hearing our voice and seeing us do this. Know that you can live your dreams, and that your dreams are only one exam question away, one test away. Think of it that way. This exam is only a chance for me to show off my knowledge. That way I can get from this stage to the next. So go for your dreams.
Yeah. See you guys next week, same time. Thank you so much.
Bye.
Bye.